Good morning again. So catheter placement and management. So the goals of access placement is essentially less than 10% of chronic maintenance hemodialysis should be through catheters. These new guidelines are out there to encourage us and dialysis centers to remove these catheters as early as possible. I know from our practice and private practice, there's a lot of push from the nephrologists and the dialysis centers. They get scored based on the percentage of patients that have long-term catheters. So you'll get phone calls for catheters to be out. So you have to really talk to your patients and encourage them to get these catheters out, not only because of the guidelines, but it's just better for the patients. So you want to educate your patients, tell them the risks and benefits of the catheters, and really explain to them why removing that catheter is so important to their overall health. So types of catheters, mostly two basic types. There's Shiley catheters and there's tunnel catheters. So tunnel catheters are the catheters of choice for temporary access for longer than 3 weeks. If someone's in the ICU, they're going to be there for a few weeks, and you want to put a tunnel catheter in as a temporary catheter, that's also acceptable. Some patients have exhausted all their access options do require permanent access via tunnel cuff catheters. And then, again, if they have a fistula that's not quite ready to use yet, you may need to put a tunnel catheter in to bridge that gap until your fistula becomes ready. And the type of catheters you want to use are catheters capable of rapid flow rates. So this is a fact that I learned. There's about 30,000 deaths per year due to improper catheter placement causing vein injury and exsanguination.
No way.
Yeah.
No way.
I found that number to be way too high.
Yeah,
but
no way. I mean, you got 350,000 people on dialysis or something. There's no way a tenth of them are getting knocked off with catheters every year.
Yeah, I found that number to be out.
Not in Houston. I mean, we got a lot of catheters, but
Right.
10% are not dying.
So there you go. So this is a basic schematic
Look
of what
out in Jersey.
Not in my hands. I was taught by the best. So
Sadly, it's not available.
The temporary catheter essentially is a Shiley catheter. The major real difference is the tunnel and the cuff. Shiley catheters are great. You get them in, get dialyzed, but you don't want to leave them in too long. The tunnel catheter, essentially the main difference is, like the picture on the right, you put it into the IJ just like you do with a Shiley, but you tunnel it out. There's a cuff. It forms a seal, reduces your risk of infection, also prevents it from being dislodged. So currently there's no proven advantage over one catheter design over another. There's split tips, there's offset tips, there's antibiotic coated, silver impregnated. There's so many different catheters out there, but really the main thing is that you find which one works for you or whichever one the hospital is letting you use, and that's the one you use. So I know this picture was shown last time with the innominate vein occlusion. You can see the artery doesn't fill. So you leave a catheter in long enough, and this is probably one of those things that happens. So this is why it's important to really talk to your patients that are, if they're going to be end-stage renal disease and be on dialysis forever. If you lose the central vein, you've lost that arm as an option for a fistula or a graft later on down the road. And that's the thing you want to stress them, is without access, they can't get dialysis, you're going to die. So again, you want to educate your patients on catheter use, how to care for them, and then to also remind them that it's just a temporary bridge to a permanent access. And you want to make plans to remove that catheter as soon as possible. So the location of the catheters, the right IJ is the preferred site. Again, it's a nice straight shot, reduces your risk of complications, and the least preferred is femoral for obvious reasons of infection. So venous access, ultrasound, I don't think I've stuck anything without an ultrasound, so strongly encouraged and should be done. The way we were always taught is you always want to see your needle tip. So you kind of want to get that plane, watch the needle go directly into the vein. My current approach is I use the probe transverse, and I kind of go long access, and I come out laterally, so it kind of gives me a nice level flat line against the clavicle, and it allows for a better tunnel so it doesn't go up and right and cause a kink and other problems. Place a guide wire in the IVC. The more purchase you have, the safer it's going to be. When you're advancing the wire, you want to kind of make sure, you don't want to let the wire loose so it's slipping in, but you want to make sure that as you're flowing and watching that catheter or the sheath tip go in, that it's forming a straight line. You're not causing any bends in the wire that are going to kind of form essentially a J-tip spear, that you can kind of perforate right through something. So the catheter tip placement, we were always told that usually when you start putting them in the beginning, you always put them a little too short. So the right tracheobronchial border is probably a good line. That one probably looks just a little bit short, maybe. Yeah.
Hard to see it, yeah.
Yeah.
Put it in the right atrium. That's what I'd say.
Yeah.
That's where the blood is, right? Put it in the heart.
Get it in there. Again, like I said last time, is watch for the azygos vein. Like we said last lecture, is that if that catheter tip just looks a little funny, it looks like it's kind of bending off right where you think it should be going straight down into the atrium, you probably want to check your catheter tip because the flow rates probably aren't going to work as well. As you can see, this is the one with the azygos where it's kind of bent off to the side. It just doesn't look right, so it's probably not right. Again, from the last lecture you guys saw, this is down in the hemiazygos. But again, if the catheter tip is in the atrium, will it work? Absolutely. So for femoral catheters, they need to be long enough and to reach the straight portion of the IVC. Otherwise, the flow volumes just aren't going to be adequate. It's going to suck down. You're going to get high venous pressures. And again, tunnel laterally, not inferiorly. So you want to avoid that kink up top. So like I said, the way I find that easy to do is I just start low and I go lateral. So I get a nice long needle stick. So it kind of forces my tunnel to be lateral. And then if you need to exchange a catheter, the way I've done it is 2 exchange lane stiff wires, put both wires down in the SVC, free the cuff, slip the old catheter off over the wire, and then you can tunnel right over that wire without having to do a new stick and start again. So complications, again, if you have an occlusion of the vein, from long-term catheter use, that's a problem. This is a balloon angioplasty that's done of the innominate, the SVC. So various tricks. Sometimes you have a hard time getting access through, but usually if you can get your wire through, you can balloon and make that space workable to get your catheter in. So infection is always one of those things that how do you manage the catheter if there's a possible infection for the catheter? If there is an infection, depending on the bacteria, you could potentially treat through with antibiotics. I know here at Methodist there's a whole protocol that we use to determine which catheters actually need to be removed, which ones need to be exchanged, which ones you can treat through. Really, depending on where you are with the help of your ID team, they might be more aggressive on making you remove more catheters. But there is data out there that says that you can probably treat some infections with antibiotics and not have to remove the catheter.
Yeah, I would just add to that, if you lose access sites, once you pull that right IJ out, that may be it. That may be done. You may not be able to get a catheter back in there. Well, now you're down to left IJ. Same thing happens there a few months later. Now you're down to leg catheters. That's not cool. So that's the reason we developed this, is because every time somebody had a fever or runny nose, we were asked to pull the catheters, and it was crazy. And there's good data that unless they're septic or growing something like Pseudomonas, you can do a wire exchange in 3 weeks of IV antibiotics at dialysis, and the patients have a low recurrence rate within the first 3 months of catheter sepsis. Hopefully beyond that, you've talked them into some other plan. Mm-hmm. Otherwise, you're just a catheter monkey, which is not what we're here to do.
Right.